GCT, Giant cell tumor, earlier known as the osteoclastoma. It is the benign, yet locally aggressive tumor, which is rarely metastasized. Metastasis in 3% cases, it is metastasis into the lungs. Skeletal, it is seen in the skeletally mature patients at the end of the long bones, that is epiphysis. Most common site is the knee, that is the lower end of the femur, upper end of the tibia, and lower end of the radius. Histology is it is a spindle mononuclear cells plus uniformly distributed multinucleated giant cells. These mononuclear cells are fuses together to form the giant cells. Due to these giant cells, it is known as the giant cell tumor, and these mononuclear cells have the malignant potential. In females presents at earlier age because of physis fuses earlier, but most common seen in the males, 2:1 ratio. It is a slow growing tumor, and patient present with the swelling, weight pain, and if attains the huge size, it undergoes into due to cortical thinning, it undergoes into the pathological fracture in neglected cases. If it is treated by the massaging or by the local bone setter due to any manipulation, overlying skin undergoes ulcerations and tumor can fungate out. That it fungate means it can let the tumor cells out of the skin and also pushes the tumor cells into the joints. Normally, GCT and ABC can look very similar, especially in the early stages in histology. In fact, about 10% of the GCT shows ABC-like areas on the histology. The debate is whether this represents the true ABC associated with the GCT or whether there are the secondary changes like ABC, like likely the changes can occur in any tumor. These differentiating features are GCT and ABC are GCT is a solid tumor filled with the soft tissue, always epiphysis. ABC is the cystic lesion filled with the blood or blood clots, mostly metaphysis, but can occur in any way, that is epiphysis or diaphysis. Age is most common presentation is the 20 to 40 years of age, rarely occur before 20 and after 55 years. Clinical features are the slow growing, locally aggressive tumor, pain due to mechanical insufficiency resulting from the bone destruction, soft tissue mass may be present due to cortical destruction. Since GCT close to the joint, there is a limited ROM of the joint is present. 12% of the patient present with the pathological fractures. Radiologically, it is the lytic lesion. Some cases seen in advanced cases seen the soap bubble appearance. It is a variable thinning of the cortices which tumor creates. And and radiologically, it is a no, well-defined non-sclerotic lesion and no mineralization and no calcification of the lesion. Mostly associated syndromes are the ABC, Paget's disease, and Gall syndrome. Gall syndrome is a focal dermal hypoplasia, multiple anomalies of the skin, tooth, and bone. There is a term called the multicentric GCT, may be seen in patients with recurrent lesions or lesions previously treated with the radiation. Um, loc Locally, it is a locally aggressive tumor treated by the en bloc resection or the intralesional excision. En bloc resection recurrence rate is 2 to 5%. In intralesional excision, recurrence rate is 20%. Um, in en bloc resection, we will go extra periosteum. In intralesional, stay within the periosteal tube. Normally, this tumor is contained in the periosteum for very long time.